Welcome to the SAB September webinar, Pleural Space Infections, part of the SAB's monthly educational webinar series. Before we get started, there are a few housekeeping items to go over. You all have joined in a listen-only mode. Please ask questions throughout the webinar by using your question feature located on your control panel. We will address all questions at the end of the lecture. Dr. Naif is our Industry Relations Chair at the SAB, and he will be moderating this evening. At this time, I'll hand it over to him to introduce our speaker.
Hello, everyone. Today we have Dr. Reza Ronaghi. He is an assistant professor at UCLA. He trained at Southern University of Southern California, did his IP training at UCLA, and his interest is in pleural disease, therapeutic and diagnostic. And without further ado, Dr. Ronaghi.
Perfect. Thank you so much. I'm just going to go here, make sure okay, perfect. Well, it's a pleasure for you guys to have me. My name is Reza, and I am one of the IP professors here at UCLA. And one of my main interests is really pleural diseases in general, but really pleural space infections. And so today I'll spend some time, hopefully, going through pleural diseases, but focusing on infections, parapneumonic effusions, and empyemas. Just as with starting any lecture, I think it's always good to start with a case presentation to give us an introduction on, to set the platform on what to talk about. So here's a quick case presentation. We have a 59-year-old gentleman who presents to the hospital after a trip and a fall and is now in the hospital actually just pending a skilled nursing facility placement. While waiting for placement, as we know, these things take some time. On day 7, he develops a fever of 39.3, becomes tachycardic, develops a cough. He continues to have worsening shortness of breath, placed on BiPAP, and then eventually intubated for increased work of breathing. On the day of intubation, his labs show a white count of 17. The rest of his labs are pretty unremarkable. Blood cultures grown a couple of days earlier show MSSA in 4 bottles. This is his X-ray on the day of intubation. So obviously you see something is happening on the right side, potentially an effusion, maybe a pneumonia, maybe a parapneumonic, and he undergoes a CT scan. So on CT scan, you can see that there is definitely some atelectatic lung, but definitely an effusion that is kind of pushing that lung. And you can see the effusion that is actually multiloculated. It's a pretty complex looking space on that right side. So he undergoes a thoracentesis. This is what the effusion looks like. So kind of this milky, thick, yellow to white material. The chemistry studies show a pH of 6.9, glucose of 4, LDH of 8,500, protein 6.5, WBC of 6,500, majority of those being neutrophils. So the question is, now what do we do? So we have a diagnosis. This gentleman's intubated, this complex pleural space with what looks to be a complex empyema. So now how do we treat this? And so hopefully throughout this lecture, I'll present some ideas on how to treat this patient. And by the end, hopefully we'll be able to answer this. So some of the objectives for today is to go over just, some pleural infections, definition, organisms that cause it, some of the epidemiology, and then to try to focus majority of our talk on really the treatment and to focus on what is the role of chest tube and drainage, what is the role of fibrinolytics, and then what is the role of surgery, mainly looking at VATS and thoracotomy, but also looking at, is there a role for medical thoracoscopy? So just as a brief start, what is the definition? Obviously, we all know parapneumonic effusion is a pleural effusion that forms in a space that is adjacent to the pneumonia. When microorganisms infect that pleural space, it ends up developing into a complicated parapneumonic or an empyema. There are a few ways that infections in that pleural space happen, and here's a good diagram showing 6 of the most common ways. The probably most common one is translocation of microorganisms from the alveoli. So this is patients who have pneumonias that end up developing parapneumonic and empyemas secondary due to that pneumonia. 2 is hematogenous spread. This is usually due to patients who have bacteremia, possibly the case in our patient, and having it seed into that pleural space. 3 is direct inoculation. This is usually post-surgical or in trauma bases. They can develop empyemas or infections of the pleural space. 4 is diaphragmatic translocation of microorganisms. And again, this usually happens in patients, let's say if they have SPP or abdominal infections, and get some translocation through the diaphragm into that pleural space, very common in sometimes liver patients. 5 is contiguous spread from mediastinal infection. So if the patient does have mediastinitis or an abscess in the mediastinum, can end up developing pleural infections. And 6, probably not so common here, however, pretty common in third world countries or around the world, is reactivation of a dormant infection. Mainly we're thinking about tuberculosis here. So here's again a good definition of some of these effusions. So parapneumonic effusion, really, we're thinking about a fluid in the pleural space in the setting of an adjacent pneumonia. These can be divided into complicated and simple effusions. So an uncomplicated or simple parapneumonic is a free-flowing effusion that is typically sterile. A complicated parapneumonic effusion is an effusion that is usually infected with bacteria or microorganisms or has biochemical properties that suggest an ongoing or a recent infection. Empyema is obviously actual organism and pus in the pleural space. A complex effusion is an effusion with multiple loculations or septations, and a uniloculated effusion is an effusion without any internal, so it's a free-flowing effusion. So for an empyema, some of the diagnostic criteria is obviously would be pus drained from the pleural cavity, pleural fluid being positive for either gram stain or culture, and also having a pH of 7.1 and lower with some clinical symptoms. Now, typically what ends up happening in empyema is you have a bacterial infection of that pleural space, and that leads to some of the chemistries that we find. And so this infection will obviously lead to a recruitment of neutrophils count. That neutrophil count, as it continues, will lead to an increase in acidosis from anaerobic utilization of the glucose by bacteria and the neutrophils. And as this continues to happen, you have the lysis of the neutrophils, which then leads to an increase in LDH. And so for this reason, you have acidosis from anaerobic utilization. So this is why the pH is usually very low, below 7.1. The bacteria and the neutrophils will use up glucose in that process of trying to stay alive. And that's why you usually will have a very low glucose, typically below 30. And you usually will have a very high LDH count because of the lysis of the neutrophils. Cultures in these scenarios can actually be negative very commonly. In over 50% of cases actually of empyema, you'll never actually be able to grow in organisms because usually it's very hard to be able to isolate a particular organism. So just because your culture is negative does not mean that it's not really an empyema. Now, what is the epidemiology? Obviously, with the advent of antibiotics, the incidence of parapneumonic effusion in empyemas has decreased to only 2 to 3% of all pneumonias, and that's just because we catch them early and we have a lot of antibiotics. But there has been some recent studies suggesting that maybe the rates might be increasing a little bit over the past 10 years. And so in a recent study looking at 11,000 patients, they found that there was a 2.2-fold rise in patients below 19 years of pleural space infections and a 1.2-fold rise in patients above 19 years. And the main reason that we can attribute this to is, one, people are living longer, and so there's more people that have more comorbidities that are predisposing them to pneumonias and obviously pleural space infections, as well as actually with a lot of new medications, we're having a lot of patients who are immunocompromised or immunosuppressed, again, putting them at increased risk of not only pneumonias, but infections of the pleural space. And so for that, we've seen an increase, and we probably will continue to see a slight increase in that incidence over the next few years. Now, let's quickly talk a little bit about the pathophysiology of how kind of this effusion starts as something really simple in that beginning stages and how it progresses to a very complex space. So in stage 1, this is usually a simple or uncomplicated parapneumonic effusion. This is where usually the interstitial fluid increases because of the pneumonia, moves across into that pleural space. The fluid here is typically free-flowing. It does start to have some exudative characteristics, and so usually the protein count is above half of the serum count. The LDH is over 2/3 of the serum count. The WBC can be variable, but it is going to start to be neutrophilic predominant. Again, these are early on stages, so you may start to have that neutrophil predominance. Fluid can still have a normal pH and glucose, like we talked about earlier. It hasn't had a chance to undergo anaerobic utilization and a decrease in glucose as much to be identified on the chemistry. And definitely at this point, no evidence of infection based on culture or on gram stain. Now we move on to stage 2. This is as the fluid starts to either linger around or become more complex. This is a complex parapneumonic effusion, or also can be an empyema, and this is known as the fibropurulent stage. In this stage, you usually have bacterial invasion across that pleural mesothelioma, which then stimulates that inflammatory response, and then subsequently leads to fibrin deposition and loculations. And so as you continue this inflammatory process, you have fibrin that starts to form in that space. That fibrin over time ends up developing septates as well as loculations, making this complex space. At this point, this effusion is going to be exudative property, high white count, high neutrophil count. Your pH will now drop, like we talked about earlier. Glucose counts will be typically below 30 or 40. You will have a high LDH count, and because of that lysis, typically over 1,000. Without pus, this is typically termed a complex parapneumonic effusion, and with frank pus, it's usually termed an empyema. Now in stage 3, this is as that fluid will sit in there longer, and you usually see this in elder population or patients maybe from SNFs who've had this effusion that's been sitting in there for a long time, have very dense fibrin deposition. And so in stage 3, you get this chronic organization. And so the fluid starts to organize. You have dense fibrous material, and you have a pleural covering of fibrinous material, also called a fibrous peel, kind of encasing the lung, making more of a trapped lung physiology, because it won't allow for full re-expansion of that lung. By many of the time, by these instances, I don't think a lot of us would really dare to just put a needle in there. And even if you do, it may be so organized and so dense that you won't be able to withdraw the fluid for either sampling or to just be able to put a chest tube and drain it. Typically, these require more surgical interventions. And so here again is a kind of summary of what we just talked about. So stage 1, that uncomplicated simple, it's usually in the first few days. It may start to have some exudative properties, low WBC count, may start to be neutrophil predominant. LDH is typically below 1,000, normal pH and glucose levels, and no organisms. These are usually going to be free flowing, and the treatment usually is going to be antibiotic alone with occasional drainage if the antibiotic doesn't take care of the fluid by itself. In stage 2, this is that complicated fibrin deposition early on stages. This usually happens in weeks after the initial onset. By this time, it does have exudative properties, high WBC count that are neutrophil predominant, LDH typically above 1,000, pH typically will now be below 7.2, be acidotic, glucose below 40, and you may develop, you may actually be able to grow and culture the bacteria, but again, it's important to identify that about half of these will be culture negative because it's just so hard to identify that organism. These are usually going to be large, more than half the hemidiaphragm. You will start to see loculations and septate. You may also identify pleural thickening on your CT or on the ultrasound. Treatment here is obviously going to be antibiotics, but you will also need drainage, and there may be a role here for fibrinolytics to break up some of this fibrin and loculations. And then in stage 3, this is that kind of chronic organized weeks to months. Fluid is going to be difficult to sample here just because they're going to be in so many different pockets. It's going to be thick fluid. Bacterial organisms typically, again, won't be present here. On CT or on ultrasound, you'll see a loculated, severe pleural thickening, many septations, many loculations. And if it's chronic enough, or in certain diseases like TB, you may end up developing pleural calcifications as well. Typically, these are going to be treated with antibiotics. And yes, you'd like to drain it, but again, most of these won't be able to get drained with chest tube or fibrinolytics alone, and typically will require some form of surgical intervention. So what are some of the organisms that typically cause pleural space infections? And it's the main ones that we think about when we think about community-acquired pneumonias or just your typical pneumonias. Strep pneumonia is one of the more common ones. Obviously, oral strep anaerobes, and Staph aureus are probably the three most common organisms. Typically, again, if you think about your community-acquired pneumonias, you're going to be thinking about Staph aureus, strep pneumonia, and those are the common ones that cause pleural space infections as well. Infections that usually come from aspiration will tend to be polymicrobial, as we would expect, and usually will end up growing a lot of anaerobes and oral streptococci. This was an interesting study by Marks, excuse me, out of the UK that looked at a 12-year study trying to identify the different organisms that cause thoracic empyemas. And so here what I'd like to show is just that first column and the second column, really showing the organisms and the percentage of patients with each of these organisms. So you can see of a total of 406 patients, 35% of them ended up having gram-positive cocci. Of those with gram-positive cocci, the most common one was streptococci, with about 20% of patients having streptococci, and staph being the second most common with 15.5%, and strep pneumonia being the third at about 10%. Now you'll notice that of, again, the total 406 patients, about 10% of patients, or 41 patients, had gram-negative bacilli. And of the most common gram-negative bacilli, majority of them were either polymicrobial or myobacterial. And again, these are usually in third world countries. But what I'd like to point our attention to here is that in 44% of cases, there was actually no organism identified. And so this is very important when you're suspecting, again, parapneumonic or empyemas or pleural space infections. Just because you don't identify an organism does not mean that that space was not infected. It is usually very hard to culture and identify an organism in these spaces. And like I said, you can see that about half of these will never grow anything on culture. Here's another interesting study that Hassan did, looking at a systematic review of the microbiology of pleural space infections. And what the interesting part that he did is he kind of divided it into different parts of the world, I guess. And in chart A here, we see it's the worldwide. In chart B, it's the tropics. In C, it's the subtropics. And in D, it's the temperate regions of whether it's the north or the south. But what's interesting, if you actually look, majority of the organisms are about the same, no matter if you're looking at worldwide, the subtropics, tropics, or the temperate regions. You can see that the most common ones are Staph aureus. It could be strep organisms, strep viridans being a common one, Pseudomonas, pneumococci, Klebsiella, as well as Enterobacter. So these are kind of the most common ones that we think about. So you're thinking strep, staph, and then polymicrobial is the most common things. Now, it is important to notice that there are certain patients that are going to be at risk of certain infections, and it's just good to keep this in the back of our mind just to make sure that our antibiotics cover these organisms appropriately. And the things that we're going to be thinking about is patients with diabetes are at increased risk of developing empyema due to Klebsiella. So you just want to make sure that in those patients with diabetes, your initial antibiotics, until ruled out, does cover for Klebsiella organisms. And obviously, in patients with influenza, you can have bacterial superinfection with Staph aureus. And so in those patients, you want to make sure that you're covering for your MRSA, at least, again, until that's ruled out. Now, what about fungal pleural space infections? And again, fungal infections are really, really rare. But of the ones that we do see, Candida is the most common one. Now, typically, Candida pneumonia or Candida empyema will usually happen in two sets of patients. One is in immunocompromised patients who have disseminated fungal infections or fungemia, and they can have translocation into that pleural space, or as a complication of a surgery, or as a penetrating trauma. So these are the ones that you usually will see it. And because that's not very common, fungal infections usually will not be a top indicator or a top causative agent. However, it's something you want to keep in mind in the right patient population. Now, TB, obviously, we may not have as much of this here. However, around the world, this is a big issue. And so tuberculous empyema can be a thing that should be considered, especially in patients who live in endemic areas. Now, two things to really, I think that is important to be able to distinguish is between tuberculous empyema and tuberculous pleurisy. In tuberculous empyema, it's where the TB organism can actually be found on stain and culture in that pleural effusions. So it's the actual organism that goes in there and causes the empyema, the infection, and the complications. However, in tuberculous pleurisy, it's actually not the organism, it's a lymphocytic effusion that usually comes from an immunologic response to the tuberculous proteins or to the organism. And so usually in these scenarios, you actually will never see an organism, and you may not culture or be able to stain any of it, because it's usually a lymphocytic response because of an immunologic response to the proteins found on TB. Now, how do we treat these patients? And obviously, first and foremost, it starts with antibiotics. And antibiotic coverage will usually start with pretty broad spectrum antibiotics, thinking about some of the organisms we've said usually cause these infections. And so your coverage is typically going to be for gram-positive aerobes and anaerobes, as well as gram-negative organisms. And so good choices typically will include clindamycin, zosyn, unicin, which give you good gram-negative and gram-positive coverage, as well as you want to cover for staph, and a good choice here is vancomycin, at least until MRSA is ruled out. And so very common agents to use is vancomycin plus zosyn, vancomycin plus clindamycin, or vancomycin plus unicin, until you either have an organism or you have improvement, at which point you may be able to de-escalate your antibiotics. Now, what about duration? There's really no good study talking about the duration, and so you'll notice that it's a little sporadic and it will change depending on which infectious disease doctor or which pulmonologist you talk to. However, in general, the typical guidelines and the typical consensus is that a parapneumonic effusion that is self-resolving, that usually is adjacent to a pneumonia that goes away on its own, will usually require 1 to 2 weeks of antibiotics with no drainage. A complex parapneumonic effusion, these are the ones that may require a simple chest tube for drainage or a thoracentesis for drainage. These typically require a little bit longer antibiotics on the course of 2 to 3 weeks. And empyema, which is just frank pus in that space, typically requires prolonged antibiotics on the course of usually 6 weeks. It's important to notice, and I see this a lot, where you put a chest tube and it's continuing to drain, and now a week or two has passed, and at what point do you take the chest tube out, or at what point do you decide the patient can go home? It's important to note that radiographic resolution typically can take months before you have complete resolution. And so even though we hope to see improvement, you shouldn't wait for complete radiographic resolution, as that can lag behind by months, and you'll either keep the patient inpatient for too long or keep them on antibiotics for a prolonged period when it's unnecessary. Now, should you drain or should you not drain? And so the typical guideline is that small or non-complex effusions can just typically be monitored closely without drainage, and they usually are self-resolving, and with just antibiotics, they usually will go away. However, complex parapneumonic effusions or empyemas obviously will not respond to antibiotics alone, and they will require immediate drainage on top of antibiotics, just like any abscess. And when we say complex effusions, we're talking about usually loculated effusions, large effusions that are over half the hemithorax, or if you see thickened pleura on CT or ultrasound, these are usually the ones that are complex and the ones that require drainage on top of antibiotics. Again, the goal of empyema treatment, obviously, is the sterilization of that cavity with appropriate antibiotics, usually on the course of 4 to 6 weeks. You want to make sure that you have adequate pleural drainage, as evidenced by either minimal chest tube output or no residual loculations on chest CT. And then obviously you want to make sure that you have complete lung expansion as you kind of clean out that empyema cavity of the effusion and of all the debris. Now, what about chest tubes? Obviously, a lot of debate, should you put a small chest tube? Should you put a large chest tube? What is the relationship to chest tube and to empyemas? So in one of, I think, the bigger studies, Raman studied the relationship between chest tube size and in patients with empyema, and they enrolled 405 patients prospectively into this multi-center study, where they wanted to look at primary and secondary outcomes. And their outcomes they looked at was death, need for surgery, hospital stay, change in chest radiograph, and lung function at 3 months. And they compared them in 4 different groups: in those getting less than 10 French chest tube size, in those in 10 to 14 French chest tube size, in those with 15 to 20 French chest tube size, and in those above 20 French chest tube size. And what they were able to find is actually that there was no significant difference between patients that either died or got referred to surgery between the chest tube sizes. And so if you look here in my box in red, this is the combination of patients who either died or referral for surgery amongst the 4 groups. In those with below 10 French, you can see that it was 36%. In 10 to 14, it was 36%. In 15 to 20 French, it was 40%. And in the above 20 French chest tube, it was 44%. And that was a p-value of 0.27, was not statistically significant. You can also see that if you separate it out into death and surgery, the percentage of patients that required surgery in each of the groups, it was 19, 17%, 19%, 19%. So pretty similar amongst the 4 groups, and obviously that was not statistically significant. And when you actually looked at their hospital stay, you can see that that was also not statistically significant, being anywhere on average 29 days, 32 days, 39 days, and 23 days. And again, that was not statistically significant. So no difference when it comes to outcomes of death and need for surgery amongst the chest tube sizes. However, where there was a difference is the pain scores. And so they divided this into 2 groups. And so they looked at the pain scores in those below 15 French chest tube and above 15. And you could see that during tube insertion, in those the above 15 French had much higher pain scores, while the chest tube was in place, so tube inside tube, you could see that in those above 15 French, again, it was much higher pain scores. With tube removal, the pain scores were pretty similar. And so you could see that in general, what they were able to conclude in this big multi-center prospective study is that smaller chest tubes do as well as larger chest tubes with the same need for surgery and death and outcomes, with the only benefit of having less pain during tube insertion and while the tube is in place. So now that we figured out tube size really doesn't matter, what about the role of fibrinolytics? So does TPA really, or fibrinolytics, have a benefit? The idea here is that you can put in fibrinolytics, hopefully break up some of that fibrin material and allow for better drainage. Again, in one of the larger studies by Mescal, it was a large prospective study that looked at 454 patients that were randomly assigned to either receive placebo intrapleurally or streptokinase intrapleurally. And so of the total patients, you can see that 226 patients were randomly assigned to receive streptokinase, and 228 were randomly to randomly receive placebo. Of the 2 groups, 206 patients in each arm were able to complete the study. And so in the streptokinase group, they got 250,000 international units twice a day for 3 days of streptokinase, and the placebo group just received saline. The rest of the care was as per routine. So they all obviously had chest tubes in place, they all had antibiotics, and there was no significant difference there. So what they wanted to look for is, again, death and need for surgery. And so you can see that there was no difference between the 2. So 64 of the 206 patients with streptokinase needed surgery, and 56 of the 221 patients with placebo required it, and that was a p-value of 0.43. So no really major difference when you looked at death or need for surgery amongst the 2 groups. However, where there was a little bit of a difference is in adverse events. And so if you look at this chart, you can see that the serious adverse events in streptokinase was 14 of the 208 patients, that's 7%. And in placebo, it was 6 of the 222 patients, and that was 3%, and that was nearing statistical significance. Now, of the adverse events, hemorrhage was seen in 7 of the 14 patients, chest pain in 4 of the 14 patients, fever and rash in 5, and other complications such as headaches, dizziness were also seen in combination with the above. So what this study really showed is that fibrinolytics alone, or streptokinase alone, really has no big benefit in terms of death or need for surgery as opposed to placebo, with the possibility of increasing adverse events, mainly being hemorrhage, chest pain, and fever and rash. And so for this reason, fibrinolytics alone are not used. Also, what the study looked at is that if you looked at the Kaplan-Meier curve at 12 months, they wanted to look at the proportion of patients being either hospitalized after 3 months or the proportion of patients being alive at 12 months. And so in this chart A, the Kaplan-Meier, you will see that between the streptokinase and placebo group, there was really no big difference at 12 months in terms of survivability. And when you look at the hospitalization at 3 months in chart B, you will see that between placebo and streptokinase, there was really no big difference. And because of this, again, fibrinolytics are not used because they have no benefit with a potential increasing in harm in patients with pleural space infections. Now, what about fibrinolytics and mucolytics combined? And so what is the idea here? So we talked a little bit about fibrinolytics, obviously, but the idea with mucolytics is that the DNA in the pleural space is the main contributor to, the viscosity that you see in empyema. And so the idea is if that we put DNAs, we may be able to reduce that viscosity. And now if you were to put TPA on top of that DNAs that has reduced the viscosity, you'll be able to break up the loculations, the septations, and allow for better drainage. So does this work? In one of the biggest studies that looked at this in the New England Journal, they looked at the use of TPA and DNAs in pleural space infections. Now, there's been a lot of other studies that have also looked at this and kind of confirmed similar results, but this was, I think, one of the original studies. This was a blinded 2x2 study looking at 210 patients with pleural infections that were randomly assigned to receive one of the 4 treatment arms. In arm 1, it was to receive TPA twice a day for 3 days. In the second arm, it was 5 milligrams of DNAs alone twice a day for 3 days. In arm C, it was TPA and DNAs twice a day for 3 days. And in the last arm, it was just placebo, which was just saline. Now, what they wanted to mainly measure was change in pleural opacity, measured typically as the change in hemithorax occupied by the effusion on chest radiograph at day 7. And then secondary outcomes was referral for surgery, hospital stay, and obviously adverse events. Now, what they found here was the combination of TPA and DNAs actually had the best benefit. So in this first row, you'll see that the change, a percentage change from the original how much of the chest was occupied. You'll see that TPA alone, there was a 17% decrease. DNAs alone was a 14.7% decrease. The combination was nearly a 30% decrease, and placebo was 17%, and that was statistically significant. Now, when they also looked at the need for surgical referral in TPA, it was 3 of the 48, so 6%. In DNAs, it was 18 of the 46, so 39%. In the combo, it was 2 of the 48, 4%. And in placebo, it was 8 of the 51, so 16%. And that was statistically significant. And when they looked at the hospital length of stay, the combination had the least hospital stay as well. TPA was nearly 16.5 days, DNAs was 28 days, combo was around 12 days, and the placebo was near 25 days, and that was statistically significant. Now, again, in this chart, you will see they're looking at the change in the size from the baseline of pleural shadowing at day 1 and day 7, and you will see that the greatest decrease in that pleural shadowing was in the TPA DNAs combo, and that was statistically significant with a p-value of 0.005. Now, when they looked at the adverse events, there was really not that many adverse events, at least serious adverse events, in the combination group. So you'll see in the TPA, it was 0. DNAs, it was 2 of the 51. In the combo, it was 3 of the 52. And in placebo, it was 1 out of the 55 patients. And that was not statistically significant at 0.22. And then non-serious was very similar at 13%, 16%, 17%, and 11%. And that was a p-value of 0.8. And so what they were able to conclude in this study was that the combination of TPA DNAs had the biggest effect on reducing the opacity of that effusion at day 7 compared to day 1. It also had the greatest benefit in need for referral for surgery and hospital length of stay. And when they looked at the adverse events, it really was not as different as opposed to the placebo DNAs and TPA. And for this reason, TPA DNAs became very popular to use in patients with complex pleural spaces. Now, what about the role for VATs? What's the role of VATs in all of this. And so again, the indication for VATS is usually an empyema that fails to resolve, usually with tube drainage or with antibiotics, or in patients with that stage 2 and higher. In one of the studies, they showed that early management and early referral to VATS is superior to just simple drainage alone. And so typically the recommendation is that usually before 2 weeks, if your drainage is not adequate, is to consider the patients for early referral to VATS. And the main reason is because the early referral to VATS will have more success rate and a less chance of them needing to do open thoracotomy, which has a much higher morbidity and mortality. And so because of these reasons, typically if you have a complex space, so usually we grade that as a grade 2 and higher, and a definitely grade 3, you should consider early thoracic surgery and early VATS. And in patients with grade 1 or early grade 2, you should consider chest tube drainage. However, if you don't have adequate drainage, you should consider early referral to VATS. And again, what thoracic surgeons typically consider early referral is anytime before that 14-day. And here you can see that on this chart, at around 14 days, this is when the probability of converting the VATS to an open thoracotomy increases significantly. And by around day 15, 16, you are almost at around a 90 to 100% chance that your VATS will need to be converted to an open thoracotomy. So typically below 13, 14 days referral is the best. Now here's the Cochrane review looking at surgical versus non-surgical management of pleural empyemas. And so this was an interesting study in that it was 8 randomized controlled studies looking at a total of 400 patients. 6 of the studies were based out of children, 2 were based out of adults. The trials compared tube thoracostomy, so non-surgical approach, and again, they could be with or without fibrinolytics, to either thoracotomy or VATS, which they considered the surgical approach for the management of pleural empyema. And what they really found was that there was no statistically significant difference when it came to mortality or procedural complications between the groups. There was a statistically significant reduction in mean length of stay in those treated with the surgical arm, but when they followed these patients up for 12 months, they found that there really was no difference in mortality between the two. So, at least my take-home message from this is, I know we think early referral to VATS, hopefully less hospital stay, earlier discharge from the hospital. However, sometimes these things may just take a lot of time to kind of heal and go away. And I think that's what sometimes makes us very uncomfortable, is as we are sitting there, it's day 13, 14, there's been some improvements, we've tried some fibrinolytics, but we're not getting the resolution on the imaging because, again, imaging lacks. We usually will refer these patients to VATS. But if you look at just the patients who got chest tube treatment, non-surgical treatment, and the ones who got surgical treatment at 12 months, their overall outcome from mortality was about the same. So really the only reason we should refer possibly to early VATS is early hospital discharge. Now here's a kind of a diagram that I really like, talking about the different stages, but mainly talking about what is the best management in each of these stages. So here's stage 1, like we talked about, typically anywhere between 0 to 2 weeks. Stage 2, anywhere between 2 to 6 weeks, and stage 3, usually at that 5 to 6 weeks onwards. And again, understand that there is obviously some overlap here. And in typically stage 1, you can see that this is usually going to be drainage alone, maybe with some fibrinolytics, and very occasionally maybe considering early VATS referral, or early, I would say, surgical referral. In stage 2, drainage usually may not have an effect, especially as you get into the latter half of stage 2. And in these cases, if you do drainage, you'll need fibrinolytics, but now you're thinking surgical options. So it's going to be VATS and open thoracotomy. And then as you get to the latter half and the end stage of stage 2, getting into stage 3, now we're thinking mainly it's going to be open thoracotomy, decortication, and thoracoplasty. And so, this is how we usually will think, depending on where on this timeline and where on this staging the patient presents. Now, as you can see on the top here, I have a question is, okay, where does pleuroscopy fit in this? Does it fit in the early stage 1, stage 2, stage 3, or does it even have a role in pleural space infections. So let's quickly try to talk about the role of potentially medical thoracoscopy in these infected spaces. So here's an article, and again, I'll start with saying there is not a lot of data looking at medical thoracoscopy for empyemas and pleural space infections. And a lot of this is just because, well, not a lot of us do thoracoscopy for this. A lot of us will do chest tube fibrinolytics, maybe referral for VATS. So that's why. And two, even if you do see studies such as this one, the overall numbers are generally pretty small. We don't have studies that are 200-300 patients for us to really be able to compare. So I'll start with that caveat. But here's one interesting study looking at the role of medical thoracoscopy in the management of these patients with multiloculated empyemas. And so their inclusion criteria was a prolonged presentation of empyema over 30 days, no response to antibiotic therapy, failure of complete drainage by tube thoracostomy, multiseptations or multiloculated empyema as seen by imaging. Their exclusion criteria was those above 70, those obviously who don't consent, bleeding disorders, multi-organ disorders, hemodynamic instability, simple empyemas that can just be treated with chest tube drainage, or complex stage 3, which will usually require full decortication, or those with terminally ill patients. Now, what they wanted to look at is, again, of their total number of patients that they had, is what was the total number of patients that had a resolution or needed surgical. So they looked at 160 patients. Of the 160 patients, 92 or 57% had complete resolution. So after pleuroscopy or thoracoscopy, they had complete resolution of the infected space and they were able to get discharged home. Of those, 58 or 36 had partial resolution. So they had resolution of portions. They may have had some scarred tissue development, some thickening pleura that never got better. So they only had partial resolution. And the remainder of those patients, of those 9, had a persistent air leak post-procedure, and 1 patient died, which is 0.6% died post-procedure. So overall, you can see that for a simple procedure that can be done with no anesthesia, it's a pretty good success rate of 57%, as well as partial resolution of 36, so overall success of around 90% for something that in my opinion, is almost equivalent to placing a chest tube in the patient. Now, what about single trocar? Here's another study looking at single trocar thoracoscopy under local anesthesia for pleural space infections. So here's a study that looked at originally 214 patients that underwent medical thoracoscopy under local anesthesia. Then it obviously separated it out to the ones that had multiloculated chronic or simple but still multiloculated pleural effusions. 21 had chronic effusions, and 8 had multiloculated pleural effusions. Of the ones with the chronic, 18 of the 21 had successful medical thoracoscopy debridement done, and 3 had to be referred for open surgery or VATS. Of the ones that had multiloculated space, 5 of the 8 had successful debridement done, and 3 of the 8 had to be sent for VATS. And so overall, if you look at their success rate, was around 80% success rate amongst their 29 patients that they did. Again, a lot of us may look at this and say, well, 80% really isn't that great of a success rate, but it's important that this is done under local anesthesia. So it's a completely different set of risk factors for those who may be elderly, who may not be able to tolerate a VATS with general anesthesia, with a double lumen ET tube with single lung ventilation. So for something that, again, in my eyes is equivalent to just placing a chest tube, because it's done through a single trocar, through the same incision as a chest tube is placed, and done under local anesthesia, an 80% success rate, in my opinion, is pretty good for those 80% of patients not to have to undergo this major surgery. And here's just a picture, obviously, of somebody who had an infection. You can see on the left side and post-treatment. So how about our own experience? And so, I've kind of spent this whole time talking about saying my interest really lies on pleural spaces and diseases of the pleura and pleural infections. And so what about our own experience? And so here's one patient that came in with a complex pleural space that on ultrasound was very complex looking. And so instead of just blindly placing a chest tube or having IR place a chest tube or doing a surgical chest tube, we decided to take the patient under local anesthesia and be able to guide our chest tube and maybe do a washout of the space. So on the left is originally when we entered the pleural space, you could see a lot of fibropurulent material, very consistent with empyema, and it was frank pus kind of that was drained from that space. The pus was completely drained. We tried to remove as much of the fibrous material as possible. We did a full suction irrigation, and the picture on the right is kind of towards the middle or end of the procedure. You can see a lot of those adhesions were removed. We did a complete washout. All the pus was removed. Some of the fibrous material is still there, which we were able to remove some of it, leave a chest tube in place, and have the patient get antibiotic treatment while the chest tube drains that space. And so here's just a video showing that same thing. So as you can see, very dense pleural adhesions, and you can see in each of these adhesions, it was a dense pocket. So again, we were able to go in with our forceps, open up each one of these pockets, drain the fluid completely, take down as much of these adhesions, all through a single trocar opening. And again, towards the end, this is as you could see, as we've removed most of that fibrous peel, it's very hyperemic, it's very erythematous, obviously very angry, but that all heals over time. And we were able to remove, again, most of that fibrous material, do a washout, and then have the rest slowly drain with the chest tube. So what about our experience so far? We've done 37 patients with empyema and parapneumonic effusions who've undergone thoracoscopic debridement and washout. So far of our 37, one has needed to be referred for VATS surgery after 6 days, just because we weren't able to completely clear that space out. And so we were able to refer the patient for VATS. The other 36 had their chest tubes removed and were discharged home. Median usually length of stay post-procedure was around 10 days, give or take. Majority of our patients are elderly patients, and I'll explain why. So average age was around 73. Most of the patients obviously had a chest tube prior to us doing the thoracoscopy. 21 of our 37 had underwent some form of fibrinolytic therapy for at least a duration of time before. There was no mortality, no complication, and no prolonged air leak. And so in my opinion, at least in our practice or in my practice, I think there's two groups of patients that are good candidates for medical thoracoscopy. By no means do I mean to say we are thoracic surgeons or that our procedures mean to replace VATS or open thoracotomy, but I think medical thoracoscopy does have a role in parapneumonic effusions and empyemas, and the two roles for it is, I think, very early on. And so if you are going to place a chest tube in these patients, again, I prefer to place my chest tubes under direct visualization for two purposes. One, it's the same risk factor as placing the chest tube. It's under local anesthesia through the same opening, with the only caveat being I can see where my chest tube is going and placing it where I like in the cavity I like. With the second benefit of, if I do see some adhesions, just like the ones, I have the ability to take them down with my single trocar, with my endopeanuts, with my forceps, to try to at least open some of that space up, sample the fluid, and maybe even do a suction irrigation through that single port before placing the chest tube. So early on, I think that's where our role stays. And in the second group of population of patients is those who are non-surgical candidates. So this is why our average age is pretty high. These are usually patients with a lot of comorbidities that, again, cannot undergo general anesthesia, single lung ventilation, double lumen ET tube. And so for these patients, we actually will do medical thoracoscopy, either with a block or just local anesthesia with no risk of the general anesthesia, no risk of the single lung, the ET tube and the single lung ventilation, and have had pretty good success. So that's, I think, where medical thoracoscopy really fits in this treatment of parapneumonic effusions and empyemas. And then obviously there's a role for VATS and thoracotomies, and you have your young patient or those who have stage 2, stage 3, who may require VATS and thoracotomies. And I think that's where that procedure really fits. So to kind of just go through in conclusion, so parapneumonic effusions and empyemas obviously result from the accumulation of fluid in that pleural space from either direct inoculation or from an adjacent pneumonia or an adjacent infection. Chest x-ray CT scans will typically show a free-flowing or an organized effusion. Diagnosis is typically made by drainage and looking at the chemistry. So again, remember, because of the anaerobic utilization, you have a low pH, a low glucose below 40, as well as a high LDH through the lysis of neutrophils. Your micro may be positive. However, remember that over 50% of these will be micro-negative. So just because you're micro-negative does not mean that it is not a infected space. Common organisms, think about what causes your pneumonia. So your strep, your staph, as well as some of your polymicrobial enterobacter organisms. So treatment typically starts with gram-positive, gram-negative, coverage for anaerobes, as well as coverage for the staph species until you at least have ruled those out. So typically you'll start with a vanc plus a zosyn, augmentin, unison combination. Empyema will always require drainage. It's an abscess that requires a drainage with a tube. In the studies that they've looked at, small bore chest tubes have very similar outcomes to large bore chest tubes when it was referral for surgery, except that the smaller chest tubes have lower pain scores. Fibrinolytics alone have no benefit, with a possibility increase in side effects. However, fibrinolytics and mucolytics together do show a decrease in need for referral for surgery and better outcomes. Again, referral for VATS, if you do consider the patient a good candidate, earlier the better, typically below 2 weeks, because after that, the need for open thoracotomy increases. However, again, long-term, there hasn't been really shown any mortality benefit of VATS, and so that's just something for us to think about. And then again, medical thoracoscopy, I do think, does have a role, especially when it is a pretty minimally invasive procedure, in my opinion, done under local anesthesia, that has had success rates anywhere between 80 to 90%. And so again, in those patients who are non-VATS candidates or in early on, I think these are the main patients who would benefit from such procedures. And I think that's the end of the talk. And so hopefully you guys were able to get a good overview on pleural space infections and kind of some of the modalities and options. And I'd be happy to take any questions, comments.
Well, thank you so much, Dr. Ronaghi. This was a monster's sort of lecture, very comprehensive. I like the review of literature and then the experience. We do have 2 questions from the audience. I think for some reason I don't see the questions again. Okay, here you go. So the first question, I think you may have answered the second part of it. So the first part is, what is the role of medical thoracoscopy in the diagnostic evaluation / management of pleural effusion in high TB burden parts of the world? The second part of the question, I think you alluded to in the last of your slides, and in the conclusion is treatment option for patients with complicated parapneumonic effusion with medical thoracoscopy, stage 1, stage 2. When is that an option? I think you kind of explained that very well. So any comment on the first part?
Yeah, no, I think, you know, actually, I think in TB endemic areas or in places where we do really consider TB empyemas and TB pleural infections, I think actually the role of medical thoracoscopy should even be higher. And the main reason is, you know, the diagnostic yield, it's really important to obviously be able to diagnose those patients correctly. And so the diagnostic yield with just thora or a simple effusion or a closed biopsy can be much lower as opposed to when you go in with medical thoracoscopy under direct visualization, actually being able to possibly take biopsies as well. And so, you know, one of the things that I always do when I do my medical thoracoscopies, even for infections, yes, I take down adhesions, but I actually do still take some biopsies of the pleura, and I do actually send some of the adhesions, not only for culture, but for biopsies as well. And so I think, you know, in cases where you are concerned about some of these more endemic or more infections that really do need a true diagnosis, that's, I think, even places where medical thoracoscopy even becomes a bigger need. And the second part, like you said, I think, you know, our role really, and what I hope to get across to everybody, is that early on group, when you see that effusion, maybe it's stage 1 or early stage 2, that's, I think, the group that benefits from medical thoracoscopy. Because if we look at that group as a whole and you do medical thoracoscopy, maybe a washout, take down whatever adhesions and place a chest tube, now look at referral for surgery, that would be, I believe, much even lower, and our success rate would be much higher than what we even have now, that 80 to 90%. So I think really we do have a role, in that early on, and then obviously in those patients who may not be candidates.
Okay, excellent. The second question, any evidence for medical thoracoscopy in early empyema being superior to conventional chest tube with TBA DNAs?
So, there hasn't been a head-to-head study, and that's it would be a great study kind of to itself to do. I can say, of my 21 patients who had undergone TPA DNAs and then, didn't have resolution, so then subsequently had to undergo medical thoracoscopy, it does make the procedure a little more challenging because there's just an increased risk of bleeding in that space. The space starts to look actually a little more, not only angry, but more complex. And so my typical now recommendation has been that when you see that complexity, before you consider fibrinolytics, to actually consider the medical thoracoscopy first, and then maybe consider actually fibrinolytics after if there is still some residual disease that you weren't able to completely clear out with the medical thoracoscopy. And having talked to some of our thoracic surgeons here, they have felt the same way in that, if we go medical thoracoscopy first and then consider lytic therapy as a second option, the kind of referral to thoracic surgery and VATS, or I should say the referral and need for VATS, has been much lower. And so, but there has been really no head-to-head study, looking at a blinded, but it would be interesting to look at.
Yeah. Another question that came from the audience is, and I had my own question on the same topic. Do you use pleuralytics after pleuroscopy? I wanted to ask you in a different way. Have you had to use fibrinolytics after you have done pleuroscopy?
Yes. So I believe in 2 or 3 of my patients I have, and in the ones that I had, it was for the ones that had really posterior adhesions that or right sitting against the pericardium, where you start to not want to maybe get too close to, had some loculations around that you completely weren't able to clear out. And so on post X-ray or post CT, you do still see residual tiny amounts. And in those cases, since they have a chest tube in place, we will consider doing a TPA DNAs. Now, one thing to consider is you want to usually at least give them 24 hours before you consider lytic therapy, just because you were in there taking down adhesions, maybe doing biopsy, so you don't want to increase the risk of developing a hemothorax. But usually in the few that I've done, it's been for residual disease, and they do have resolving after it's done. They do have that residual disease be gone. Usually 24 hours is my at least safe window onwards to consider it.
A couple of technical questions. I think I may know some of the answers to this, but we definitely have to see what you've been doing in practice. What type of fluoroscopy do you use? Semi-rigid, rigid thoracoscopy? Any data comparing on the techniques? Which is preferable? Semi-rigid versus flexi-rigid. I think you use a flexible, right?
So we actually, majority, I would say we use a rigid actually. Now we have the option of obviously doing the flexible or the semi-rigid as well, but majority of ours are rigid. The benefit I will say to the flexible is to try to get into very tough angles. Some of, again, that posterior kind of sitting right along the pericardium can be difficult to reach with the rigid. But it's just the amount of tools and the size of the tools that can fit through a rigid are usually much more, hence why 90% of our cases will be with a rigid.
Okay. And then do you do this in OR or endo, and what type of training the staff has in the process of doing that?
Yeah, we do 100% of our cases in the operating room. We treat it as if it's, a VATS, sterile, the whole, as if it's any OR procedure. And then our staff here is actually very well versed with our procedure. So they are trained to, do pleuroscopies, not only from an anesthesia, but from our nursing to, the OR techs. And the reason that's important is because of the tools you may need in case, let's say, you need to do cautery while you're in that space, in case you do need, let's say, more endo peanuts or something to take down more adhesions, bigger forceps. It's good for them to be familiar. And two, because we do these a lot under local with maybe just a little sedation with some fentanyl or propofol or Versed that are anesthesia colleagues, the anesthesiologist has to be comfortable with that. And so it's really important to have everyone on the same page, because one of the main questions I get a lot of times is, okay, so are we going to put this patient under general? Are we going to do a double lumen T-tube? And the answer is no. So it's very good for them to be versed with your procedure. It'll make it easier, obviously, on you, better for the patient.
Okay. I had a question. I wanted to know, one question is, what's your follow-up sort of protocol? Do you ultrasound them daily, x-ray daily? How long do you leave the chest tube in after the pleuroscopy? And what's your decision? Do you use a cutoff that 150 cc drained, or do you like to see radiological resolution? Just kind of walk us through.
Yeah, so typically, again, all of them obviously have a chest tube. Average, I would say they're in the hospital for 1 to 2 weeks. I think my average, I would say, is anywhere between 10 to 11 days. During that time, they're getting antibiotic therapy and obviously on continuous suction through that. Typically for infections is a little different than, if you're looking at malignant effusion. So for infected spaces, I usually like to see almost zero output before I pull the chest tube. And so I usually will wait 24 or 48 hours of zero output before I consider pulling it. I do get daily x-rays on them, so they're getting everyday morning x-rays because you want to make sure your chest tube isn't clogged. So we usually will flush the chest tubes on a daily basis just to ensure, especially with some of these that are very high viscosity, you want to make sure your chest tubes don't get clogged. So we do x-rays every day, flush the chest tubes every day. Once there's no output, then we consider pulling it, but we also look for some radiographic resolution. So obviously post-procedure is the biggest change you hope to see, right, where your effusion and your adhesions are completely gone and hopefully most of your lung is up. That's the biggest resolution. And then on a day-to-day basis, you want to make sure that actually the effusion isn't coming back, the loculations aren't coming back, there's no bleeding in that space. And so as long as I see some radiographic resolution and my chest tube output has been zero, then at that point I pull it. And again, on average, I would say it's 1 to 2 weeks that they're in the hospital for that.
Okay, excellent. We have a question from the audience, and we're kind of running over time, but who makes a semi-rigid? I'm thinking like a company, or I'm guessing that's the question.
I know the rigid that we use is Stores, and then the flexible is really like you could use the Bronchoscope. So a lot of people will use the Olympus, they'll use the Ambu. The semi-rigids, I'm actually not sure. We don't use semi-rigids. We only use the flexible and the rigid. So I'm actually not too sure who uses the semi-rigids.
Reza, and then this is the last question here, and we'll finish this webinar. I know that there's some folks out of the Boston area use a blunt dissection technique. Have you had any experience and difference, and how would you make that intraoperative decision? Number one. Number two is, I know that we made this classification of stage 1, stage 2, and stage 3, and then that's clearly if you're in the pleural space. Do you use the ultrasound to pre-stage the patients before you go in, or do you have to go in to really know what you're dealing with or what type you're dealing with? And that's, I think we'll finish that webinar.
No, I think that's a great question. And, I think I would say probably 100% of our patients, first of all, will have a CT scan. So you at least have an idea what that pleural space looks like. But I ultrasound 100% of my patients right as I'm about to start the procedure, mainly actually for my planning, because by that ultrasound, not only can I see where the diaphragm is, so I can, I always make a part marking of where my diaphragm is, so I know obviously above where to go as I'm positioning the patient, but also to give me an idea how complex that space is. Do I see free flowing fluid, just a few septations, lots of loculations? Do I not even see the pleura? Do I see the pleura? So it kind of gives me an idea. And the reason that's important is because during my insertion into that pleural space, now, if you see a big pocket of fluid that's 3 liters and you don't see any septations, you can just go in with your Kelly clamps or, that blunt dissection And well, you know you're going to be in fluid unless you don't go 4 or 5 centimeters deep. You'll be safe. But in the cases where you do have adhesions, loculations, and septations, it's sometimes hard to distinguish which one of those is really lung. Is it all septations? Is there lung embedded in that? And that's where it becomes a little tricky. And for those cases, what we usually will do is dissect down to the pleural space. And as you dive slowly into the pleural space, we actually will use that blunt dissection. Usually we'll use our finger first to go in there and feel what we're feeling. Make sure that if there is adhesions, be able to bluntly take those down with your finger. And then as you take down that space, be able to maybe feel the lung, and usually the lung starts to feel rock hard by that time when it's that complex. And once you feel the surface of the lung, now you can go in with your trocar. Once we put in our trocar and our camera, you know, now we still will use blunt dissection, because even now you know you're in the pleural space, it's very hard to identify where you are. So we'll use, you know, what we call endo peanuts, or really long tubes with just cotton at the tip, which allows you to go and kind of push aside the adhesions until you can identify where is your visceral pleura, where is your parietal pleura, where is the pleural space, and then identify where you are and then start peeling away. So in the complex ones, you want to be really careful as you enter that pleural space and use your finger and blunt dissection before you accidentally enter the lung parenchyma or an organ you don't want to.
Excellent. This was great for me personally, and I think the audience probably enjoyed it too. Thank you so much, Dr. Ronaghi, and we would love to have you back again on some other time. Okay?
I would love to be back, and thank you guys for having me.
Of course, anytime.
Take care.
Thank you, everyone. Have a wonderful evening.